I think one of the biggest questions surrounding menopause is hormone replacement therapy,
Hmm.
and what is that? And there's certain ages that you should start it, and there's certain ages that you no longer should start it, and it's kind of there was a while there that seemed like it had a bad connotation as well.
No, definitely. So, I would say like the peak use of hormone replacement therapy was in like the late 1990s, early 2000s. We
Mm.
in the year 2000, about 25% of menopausal women were on hormone replacement therapy. And I was a resident back then at Sinai, and we knew anecdotally that estrogen had such protective benefits for women in terms of
Mhm.
their dementia and Alzheimer's risk and heart disease. So we kind
Right.
of, if anybody was symptomatic, we started them on HRT. We didn't have a lot of choices. Mainly, it was a pill, and it was a synthetic estrogen, actually derived from pregnant horses. Prem Pro,
Right.
pregnant mares. And then the big women's health snitch sort of study came out in 2002. And, everything that we thought was true based on their initial analysis was not. So they stopped the study and everybody came off of it. They said, there's a big splashy headlines, New York Times, Wall Street Journal, Good Morning America, and Matt Lauer. Everybody was like, women should come off of hormones. This is increasing your risk of heart, strokes and blood clots and breast cancer. And then we kind of deprived a whole generation of women from HRT after that for about 20 years.
Hmm.
And just recently now in the 2020s, it's kind of made a resurgence with newer data coming out from Europe, some American data, some Australian data that actually that initial analysis was a little bit faulty if you looked at women that were just going through menopause. So if you were 50 to 59, you still
Hmm.
had all the benefits of decreased breast cancer, decreased heart disease, decreased rates of Alzheimer's and dementia, decreased colon cancer. It was that the age group was so wide that they were studying. It was 50 to 69, and the average age in the study was 63. 63-year-old woman is very different than a 50-year-old woman who's acutely going through menopause. So hormone replacement
Right.
therapy is generally three hormones, where your ovary is making estrogen, progesterone, and testosterone. Most commonly, it's estrogen and progesterone because those are the two that are FDA approved. So we now know that giving the estrogen transdermally, meaning doing it as a patch or gel or even a vaginal ring, and not taking it orally, not having it metabolized by your liver is a lot safer for women. Decreases the risks
Oh.
of blood clots, decreases the risks of strokes or those thromboembolic events, and
Hmm.
even the possible risk of breast cancer because of those free radical formations. We give that as a patch, and then we do an oral progesterone. The metabolism of progesterone in the liver is actually kind of nice because it releases a lot of good GABA and kind of helps you to relax. Progesterone is the feel good, happy, dopey, sleepy hormone.
Hmm.
So the combination of the two, one helps with the hot flashes, prevent, protection of bone, heart, brain, and the other one is really kind of helping a lot with your mood and sleep. And then the third one is testosterone, which the FDA has not approved yet. We're hoping it will be within the next 2 or 3 years. It is approved for
Hmm.
use in women in Australia and certain parts of Europe. And that's the other one that the ovary really makes. And actually, believe it or not, before menopause, you have a little bit more circulating testosterone than you do estrogen if you actually look at the total amounts that are in your blood. So testosterone has three benefits. Everyone kind of thinks of it as just being the libido driver, but it can help obviously with libido and sexuality. It's also the major driver for women, just like it is for men. Helps with like mental clarity and fatigue and, just feeling a little bit more sharp. And then the third thing is protecting your bones and protecting the muscle mass that you have. Women lose a lot of muscle in midlife and especially in perimenopause and menopause. And the testosterone can kind of help with what we call sarcopenia or loss of muscle. So, and as we are doing more and more longevity, and you guys, there were a lot of talks at Branchella Porta when I was there just a couple of weeks ago about, lifting weights and what's tied to having more muscle mass and longevity.
Hmm. So it's interesting that the ovaries actually make testosterone as well. It just
Hmm.
kind of shows how related our
Yeah.
body parts are, men and women.
Yeah.
So do all the hormone levels include? So testosterone also drops at a certain age during menopause for women.
Hmm. Yeah, because testosterone is made in the ovaries, and a little bit of it is made in your adrenal glands and in the fatty tissues of your body. So it may not drop down to almost zero, which the estrogen levels will for most women, but it'll drop significantly, and in some cases will be undetectable or very, very low amounts.
So in the past, I feel like using the synthetic that came from a horse
Hmm.
was was one of the things that was considered a red flag. Is the news is it what are they using for the new hormone replacements?
So it's estradiol, which is more similar
Which
to what your body's making. So it's more
okay,
bioidentical. So bioidentical can be made in big pharma. You don't have to have it compounded in a special pharmacy.
okay,
You can get a prescription and pick it up at CVS or Walgreens. But chemically, it's estradiol, which is very similar to what your body was making. And then again, it's transdermal. So most women are getting it as a patch that they change twice a week,
okay,
or a gel that they apply and air dry every morning, or there's even a vaginal ring that you can insert and slowly
right.
releases it through the vagina and it's absorbed that way. The oral Prempro is almost never used. Every once in a while, I'll see a patient on it who's been on it for a long time, or maybe has, a doctor that really hasn't kept up with some of the
Mm.
changes in HRT, and we'll try and transition them over to something that may be a little bit more natural to what their body was making and a little safer for them.
So estradiol also includes progesterone then?
No, so progesterone is a separate
Oh,
medication, a separate compound. So you have to
but
get
the same
estrogen
thing.
and progesterone.
So is it the estrogen that's hard on the liver to digest then?
Yeah. So when the estrogen gets broken down in the liver, it makes more free radicals and it makes more things that can be detrimental to your blood clotting and blood clots and stroke. The
Oh, I see.
progesterone, when it's metabolized by the liver, actually releases some nice byproducts that actually help you to relax and sort of chill out and feel a little more, you know,
Right.
even keeled and sleep better. Progesterone can be a game changer for sleep.
I need a little of that then, I guess. But um, so I was also I would imagine that not every woman is going to need the same levels of all these of the
Mhm.
different hormones. So do you test each person individually to see where their levels are, and then you just try to keep them in a certain level or range?
So actually, that's a really good question. We don't normally check levels. So we
Okay.
know that everything's going to be kind of low. And depending on your age and how far you are into the whole perimenopause, menopause journey, we pick a dosage and then we titrate it based on your symptoms. And the reason for
Okay.
that is because the normal estrogen levels are so varied. Like a normal estrogen can be between 50 and 350 to 400 in most labs. And that's because
Wow.
yeah, that's because the normal menstrual cycle has such fluctuations in the estrogen as well.
Okay.
So if you're at the very beginning of your period, your estrogen is going to be very low. It'll be closer to 50. If you're in the middle of your cycle around day 14, when you're getting ready to release that egg and ovulate, it'll be like 2 or 300. And then right before your period, it's going to be somewhere in between because the egg is not fertilized.
Mhm.
You're about to get your period and the levels are dropping. So,
Right.
me at the age of 35, and let's say you were a woman, you at the age of 35, we may have lived at different numbers. So to artificially treat each woman to, let's say, a level of 200 or 150, it's very artificial. So we don't normally follow blood levels, and you don't need, blood tests to be diagnosed as being menopausal or even perimenopausal. So we do that based on symptoms pretty much. The only times that we do check blood levels when it does become important is if somebody is on therapy and is not feeling any better. So normally when I
Mhm.
start my patients on HRT, I check in on them again in 6 to 8 weeks, I either see them as a visit or a telehealth, like, hey, how's it going? And they're like, I feel no different. Not that I don't feel fully better or, I'm having side effects.
Mm,
I feel nothing. Then maybe they're just not good absorbers. So, when you're giving the
mm,
medication through the skin, some women just don't absorb it as well. And so
mm.
that might be a time to check levels. So if they've been on appropriate therapeutic doses of estrogen, but the blood work
Mhm.
doesn't reflect that, then they may be somebody that needs to take it orally, even if it's going to get
Right.
metabolized by their liver. If somebody was feeling really great on it and all of a sudden isn't, that's another time to check the levels. If we're going to put you on testosterone therapy, we always check levels because giving too much testosterone can really have some bad side effects for women. So that is something that I watch very carefully, and I make sure that the patients are in a very tight therapeutic range with testosterone. But the other two hormones, estrogen and progesterone, we don't need to follow those.
So, is there a standard therapeutic dose that you would give? And it's based on the number of symptoms and the severity of the symptoms?
And the age. So if a patient is like
And
52, and she's going, through the thick of it, she may need a little bit more. If somebody's 55 or 56, her needs may be changing. I also kind of look at the BMI and the size of the patient, how much, I think that they're going to need. But really, it's based on like their symptoms and really where they are in their menopause journey. And that can also change. Somebody who's in perimenopause at 48 or 49 who's still making some estrogen of their own, they may need more when they go officially fully through menopause and they're making no more estrogen. That same patient
Right.
closer to 58 or 59, when, she's a few years into it, may need a little less because her symptoms will naturally go down a little bit,